if it occurs, we should we should treat the baby as fast as we can, because we want to prevent the ammonia to climb up further. So the outline of my presentation is what is hyperammonemia, the causes of neonatal hyperammonemia, and I will give you one case presentation that occurred in our hospital. Ornithine transcarbamylase deficiency, which is a part of the urea cycle defect. What is the urea cycle? The ornithine transcarbamylase deficiency enzyme in the urea cycle. The inheritance pattern of OTC, clinical features, laboratory findings and imaging, diagnosis based on DNA analysis, and the treatment. Among the most important laboratory findings associated with inborn error metabolism, we present with an acute encephalopathy. That is present with acute encephalopathy is hyperammonemia. A plasma amino level should be obtained for any infants with unexplained vomiting, lethargy, or other evidence of encephalopathy. The significant hypoammonemia is observed in a limited number of conditions in inborn error metabolism, including the urea cycle defect, especially OTC and citrullinemia, and many of other organic acidemias are on the top of the list. It can also be seen in the severe form of several long-chain fatty acid oxidations, such as CPT2 deficiency. So ammonia level in all of these conditions may exceed 1000 micromole per liter. The findings is markedly hyperammonemia, and it will provide an important clue to diagnosis and indicates the need for urgent treatment to reduce the ammonia level. The degree of neurological impairment and development delay subsequently observed in infants and children with urea cycle disorders. This is a flow chart for differentiation of hyperammonemia in newborn. The timing of the onset of symptoms may provide an important clue. An infant with urea cycle defects typically do not become symptomatic until after 24 hours of age. The symptoms in the first 24 hours are characteristic of 10, which is if less than 24 hours, mostly it is a transient hypoammonemia, or it might be due to other inborn errors metabolism, such as organic acidemia or what they call pyruvate carboxylate. If the symptoms more of age, usually urea cycle defect or an organic acidemia in infants occur. With organic acidemia, typically exhibit a metabolic acidosis and ketonuria, and metabolic acidosis is not a feature in urea cycle defect, unless there is shock in a complicating features. The plasma amino acid analysis is helpful in the differentiations of the specific defects in this group. The characteristic of amino acid abnormalities provide a definitive diagnosis of citrullinemia and adenosine aciduria. Although there is no diagnostic amino acid elevation are observed in carbamoyl phosphate synthesis deficiency or OTC deficiency, a low or undetected level of plasma citrulline is observed in both of these conditions. Carbamoyl phosphate synthesis deficiency and OTC deficiency may be differentiated by measuring of the urine uric acid, as in carbamoyl phosphate synthesis deficiency is low uric acid, with OTC had elevated of uric acid. So for the case presentations, we have a boy, which is baby of AA, delivered in August last year, 2022. He was born full term via a cesarean section for primary dysfunction labor. The birth weight is 2.98 kilo, which is above a 10 centile. The mother is 27 years old, Parawan, with a good socio-economical background, antenatally only have GDM on metformin with HbA1c of 5.3%. He delivered cesarean sections and the baby born vigorous with good AVGA score. Directly skin-to-skin contact and breastfeeding have been initiated in the OTs, and the baby initially was discharged to mother. Baby was fully breastfed and the diagnostic monitoring was normal. All the recorded vital signs were stable and baby was discharged well to mother. On the day of admission, around day 3 of life, 60 hours of life, patient was admitted for neonatal jaundice with 10% of weight loss. The history was patient discharged well to home with breastfeeding on demand every 2 to 3 hourly. At midnight, patient become irritable and refused for feeding. While at home, patient remains afebrile. Mother had visited the KK and the next morning and then was referred to SUSMED for poor feeding with weight loss and neonatal jaundice. Upon our first examination, the patient looks completely well. There is no septic looking, no irritability. The sucking was good, except for the jaundice. There is weight loss of 10% with vital signs were unremarkably normal. The blood counts also shows no signs of infections, except from the bilirubin is slightly high. The blood gas initially is respiratory acidosis with slightly high lactate 4.7. We nearby mouth this baby as the blood gas shows slightly high lactate, and we started on penicillin and gentamicin infusions. Phototherapy was started as well. At 2 hours later, around 62 hours of life, in our NICU, the baby had respiratory distress. There's intermittent grunting with tachypneic, but still moving and alert. The perfusion was still normal. Vital signs are relatively normal except for tachypneic. We started him on non-invasive ventilations. The blood gas shows the same, which is respiratory acidosis, slightly high lactate. At 66 hours of life, the patient was cyanosed, apneic, desaturated with bradycardic as well. After PPV and subsequently, we intubated this child. The blood gas post-intubation shows already compensated metabolic acidosis with increasing of lactate. Central umbilical catheter was inserted and full sets of bloods were repeated, including serum ammonia level. When we informing the parents regarding the patient condition and status, then the parents revealed that they had relative with early neonatal death. From the further history, the patient cousin from the maternal side, which is the second child of the mother's sister, a baby boy, also had similar presentation at similar age, in which intubated and passed away in HKL at around day 7 of life. The diagnosis was ornithine transcarbamylase deficiency, which is part of the urea cycle disorder. The mother eldest brother also passed away 38 years ago at day 7 of life after formula feeding. At 69 hours of life, saturation able to maintain, but the perfusion was poor. There is hyperglycemia episode in which required insulin infusion. Bedside scan shows cerebral edema. Subsequently, the baby developed neonatal seizures, which is 2 episodes of jerks movement, and the blood gas that time shows compensated metabolic acidosis with climbing of lactate to 9.9. Our first serum ammonia at that time was already 2,686 micromole per liter. We did give a sodium bicarb correction and also phenylbut loading and maintenance dose for the seizures, but we are unable to give hyperammonia cocktail at that time due to it's not available in SUSMED. As well, we are unable to do the renal replacement therapy at that time as it was not an option. The next morning, at 75 hours of life, the blood gas worsened, showing mixed respiratory and metabolic acidosis. with increasing of lactate. The second serum ammonia was 2,800 already, and this case was discussed with the metabolic specialist in HKL. And after discussion, we decided for conservative management for this baby. The parents were counseled and understood about the conservative management, and we did send for IM study, DNA extraction, and OTC gene analysis to IMR. We also refer the parents to genetic counseling for in genetic metabolic HKL. At 85 hours of life, after a few hours, death was pronounced with cause of death of ornithine transcarbamylase deficiency with hyperammonemia. So the inborn error metabolism result came back as a suggestive of consistent and suggestive of ornithine transcarbamylase deficiency, as there is moderately elevated of urine uric acids with elevation of the organic acids with also normal citrulline and arginine. So what is ornithine transcarbamylase deficiency? It is a deficiency of enzyme in the pathway of the urea cycle. So for your information, OTC is part of urea cycle disorder. In urea cycle disorder, there are 6 diseases that involving the 5 enzyme and 1 cofactor. And urea cycle disorder is a part of the major diagnosis, which is inborn error metabolism. Based on the National Institute of Health, the overall calculated prevalence was 1 in 35,000, with 2/3 presenting with initial symptoms after newborn period. The mortality rates to be 24% in neonatal onset cases and 11% in the late onset cases. This is the urea cycle. As the ammonia is a normal waste product formed when the body breaks down from proteins. However, the ammonia will become toxic if the levels are high. As happened, it is not properly removed from the bloodstream. The brain especially is sensitive to the high level of ammonia, and increasing of ammonia can cause severe and permanent brain damage. Ornithine transcarbamylase is an enzyme that is critically important in the conversion of ammonia to urea inside the liver. After urea is formed in the liver, it travels to the bloodstream to the kidneys, where it is eliminated from the body in the urine. OTC deficiency is one of the several disorders among the genetic under urea cycle disorder. OTC deficiency is X-linked disorder because the gene is on the X chromosome. Since boys have only single X chromosome, they will have a severe disease compared to girls, as girls have 2 X chromosome. So the girls will be the carrier. Urea cycle defect, actually, as I mentioned before, OTC is under urea cycle defect. There is 5 enzymes with 1 cofactor that involved in urea cycle. The urea cycle begins in the mitochondria of the hepatocytes and ends in the cytoplasm. The first step is involving the conversion of ammonia into carbomoyl phosphate via the enzyme of CPS1. And increasing levels of carbomoyl phosphate will be converted into uric acid. After that, carbomoyl phosphate and ornithine combine to form a citrulline via OTC. Citrulline is then transported from hepatocyte, mitochondria to the cytoplasm. Citrulline reacts with aspartate to form arginosuccinate. The reaction is carried out by the enzyme of arginosuccinate synthetase, which requires ATPs. After arginosuccinate is converted into arginine via arginosuccinate lyase, the reaction also gives off a fumarate. And the final step is arginine undergoes the hydrolysis via arginase to form urea and ornithine. Ornithine transcarbamylase deficiency, actually Uracycle defect is autosomal recessive disorder. Most of the uracycle defect is autosomal recessive, exception for OTC deficiency, in which OTC is an X-linked. So homozygous males usually are more severely affected than heterozygous females. Approximately 10% of female carrier may become symptomatic. For females, the clinical severity varies on the pattern of X chromosome inactivation in the liver, also known as lionization. As the OTC is X-linked genetic conditions, as it is located in the X chromosome, the girl will have two X chromosome while the boys have X and Y. Since the boy have only X chromosome, if there is abnormal or missing of OTC enzyme, they have no backup. So the boy will have the disease. So the girl, we only become carrier, but can be, because of lionization, the girls also can be become a disease. Women with one abnormal OTC gene will pass on to their children 50% at that time. If the infant is a girl, she will be a carrier, and the infant is a boy, he will have a disease. If a man with OTC deficiency, if the man has a child, if it is a boy, the boy will not have OTC. But if it is infant, if it is a girl, the girl will inherit the X chromosome and become a carrier. For the clinical features, there is two clinical features, which is the typical presentation and atypical presentation. Normally, baby was well for the first 24 to 48 hours after birth, but after, subsequently, the baby becomes symptomatic after feeding. A common early sign in newborn with hyperammonemia is central ventilation. Hyperventilation leads to respiratory alkalosis. Hyperventilation is the result from the cerebral edema caused by accumulation of ammonia. Approximately 50% of infants with severe hyperammonemia will have seizures. For the atypical presentation, patients who have partial enzyme deficiency may have atypical presentation, such as after newborn period, such as in the carrier. Some patients will present with chronic vomiting, development delay, seizure disorder, sleep disturbances, or psychiatric illness. Others may also develop symptoms following the catabolic stress or increase of protein intake. The hyperammonemia is often less severe in this group, and associated symptoms are more subtle. For the laboratory findings and imaging, typically the blood counts will show no evidence of infections. Initial plasma amino level was significantly elevated with high lactate. Subsequently, the liver function will worsen and the child will develop coagulopathy. Imaging in acute presentation will show evidence of cerebral edema. If the plasma ammonia concentration is greater than 100 or more than 150, further testing need to be performed to establish the diagnosis in any case of the babies. Additional testing is used to identify specific enzyme deficiency, including the enzyme analysis and molecular genetic testing. This is the quantitative plasma amino acid analysis to help us to differentiate among the uracycle disorders. When the child present with hyperammonemia with normal pH or alkalosis with normal glycemia, uracycle disorder should be suspected. It's either if there is a low or absence of citrulline, it's either CPS deficiency or OTC deficiency. So the next step, it will be the urine orotic level. So if it is high, it shows more towards OTC, and if it's normal or low, it shows more towards CPS deficiency. DNA sequencing-based mutation testing is clinically available for all genes of the uracycle and increasingly used as the first-line approach for diagnosis. The DNA testing for OTC deficiency should be considered because OTC deficiency is the most common in urea cycle disorders. More than 150 pathogenic variants in most of its single base substitution have been reported. However, microdeletions of parts or all of the OTC gene may lead to false negative result in the DNA sequencing. Hence, array comparative genomic hybrid or chromosome microarray analysis to detect the macrodeletion of the gene is indicated when initial DNA sequencing is negative. For the treatment of any urea cycle disorder or specifically OTC, the initial approach of this treatment is consists of the following, in which rehydration and maintaining good urine output. We need to remove the high accumulation of ammonia from the body, and we need to stop immediately the protein intake to minimize the catabolism. Our goal is to maintain a normal ammonia levels to prevent the brain damage. Within 48 to 72 hours, the results of amino acid and also organic acid analysis should be available, allowing us to confirm the diagnosis in the most of the cases. In critically infant with hyperammonemia, arrangement should be made for hemodialysis if available or continuous renal replacement therapy. Maximal supportive care should be provided simultaneously in inborn error metabolism, and bicarb therapy is clearly and urgently indicated. After removing the toxic metabolites, the second major goal is to prevent catabolism. So 10% of glucose should be administered intravenously, with higher concentration should be administered as well, up to 20% or 25%. We did give intralipid 20% with a dose of 2 to 3 grams per kilo per day to increase the calorie amount. Protein-free formulas such as pro-free, calolipid, or basic pay were administered as well. So we need to anticipate the complication, such as if there is hyperglycemia, insulin infusion should be started. If there is fluid overload, you should give a mini boluses of furosemide. If the electrolyte is imbalanced, we should correct the electrolyte imbalance. Protein should not be withheld indefinitely. If the clinical improve, we need to add on IV vitamin or oral natural protein after 48 hours with the lowest dose of 0.5 gram per kilo per day. For a baby like our baby with high ammonia level, anti-hyperammonia cocktail drugs is indicated when the ammonia is more than 200 and there is encephalopathic symptoms. Loading dose of IV sodium benzoate, IV sodium phenylbutyrate, and L-arginine mixed together inside a dextrostan will be infused over 1 hour to 2 hours, and then subsequently followed with the maintenance dose with the same dilution for 24 hours. Subsequent treatment is needed and should be discussed with the metabolic team HCare. If the ammonia level is more than 400 micromole per liter with worsening encephalopathic symptoms, or there is no reduction of ammonia despite of the cocktails, dialysis is indicated. And in babies, due to unavailability to perform hemodialysis, the only approach is peritoneal dialysis. That's all from me. Thank you.
Okay, thank you, Dr. Rizwan, for the informative and interesting talk. So I think it's very important for us to know about the hyperammonemia in baby because if baby came in with you with sudden onset of collapse within a few days, so please think about the inborn error of metabolism. You can have other diagnoses such as congenital heart disease, for example, in critical aortic stenosis of sepsis, but sometimes we forgot about the inborn error of metabolism. And with that, I think we come to the question and answer session. If you have any question, please feel free to ask, or you can write in the chat box. Any question? Okay, I think if there is no question, so we come to the end of our presentation. So I would like to say thanks again to the presenter for the informative and interesting talk. So hopefully the presentation will be beneficial for everybody. And thank you for your attention. Assalamualaikum warahmatullahi taala wabarakatuh.
Thank you, Dr. Rizwan. Thank you, Dr. Najib.